Okay, let's dive into this. Welcome to today's Explainer, where we're going to take a really close look at one of the most misunderstood and, frankly, most severe conditions in the entire medical landscape, anorexia nervosa. A lot of times, public perception kind of reduces this illness to a lifestyle choice, or just a simple desire to be thin. But as we'll see, the clinical reality is vastly more complex. It's deeply physiological, and it's profoundly serious. So we're going to explore exactly what medical science tells us about the diagnostic criteria, the intense physical symptoms, and the evidence-based treatment options available.
Here's our roadmap for today. First up, the diagnostic criteria. Second, the systemic toll. Third, the metabolic crisis. And finally, paths to recovery.
Section 1. The diagnostic criteria. How do we actually define anorexia nervosa?
To truly understand what's happening here, we have to shatter some common misconceptions and look straight at the official medical definition. Clinicians use the DSM-5-TR, and it lays out 3 core criteria. First is criterion A, which is the restriction of energy intake relative to the body's requirements, leading to a significantly low body weight. Next is criterion B, an intense fear of gaining weight or becoming fat, or exhibiting persistent behaviors that block weight gain. And third, criterion C, which is a disturbance in how a person actually experiences their own body weight or shape. Now, what's really interesting about this slide is how perfectly it captures the dual nature of the illness, right? It's defined by both a very measurable physical restriction of fuel and this intense, overwhelming psychological distress that completely warps self-perception.
Underneath that main diagnosis, doctors also classify the illness into 2 distinct subtypes. And this is based entirely on the behaviors a patient has shown over the last 3 months. On one hand, you've got the restricting type. This is where weight loss comes primarily through dieting, fasting, or excessive exercise. On the other hand, there's the binge-eating/purging type. This involves recurrent episodes of binge eating or purging behaviors, things like self-induced vomiting or misusing laxatives and diuretics. And recognizing these subtypes is absolutely crucial, because as we'll see, they lead to entirely different physiological emergencies.
So how do clinicians measure the severity of the illness? For adults, they use body mass index, or BMI. A BMI of 17 or greater is classified as mild. It drops to moderate between 16 and 16.99, severe is in the 15 range, and extreme is categorized as a BMI of less than 15. But, and this is a big but, the DSM-5 doesn't just rely on rigid absolute cutoffs. A doctor's clinical judgment is highly informed by the patient's age, what their weight was before the illness, and critically, how rapidly they lost the weight.
Section 2. The systemic tool. Let's look at the body under extreme stress.
When a person restricts their energy intake to this severe degree, their body goes into a state of profound shock. I want you to think of it like a high-performance engine that's literally being forced to run without any fuel. It doesn't just slow down, the systems fundamentally start breaking apart just to survive. And one of the most surprising and, honestly, tragic physical adaptations the body makes in this starved state is the development of something called lanugo. This is the growth of really fine, downy hair all over the body. Because the patient has lost their insulating layer of body fat and is often dealing with hypothermia, the body desperately grows this layer of hair as a physiological response just to preserve heat and survive the extreme cold and emaciation.
But those adaptations definitely don't stop at the skin. That starving engine breaks down across every major system. Cardiologically, patients often experience bradycardia, which is a dangerously slow heart rate as the body desperately tries to conserve energy. Down in the gut, we see delayed gastric emptying and severe constipation. Hematologically, there's neutropenia, so a dangerous drop in white blood cells. And endocrinologically, the body basically just starts shutting down anything non-essential. This leads to hypothalamic amenorrhea, which is the loss of the menstrual cycle, and a severe decrease in bone mineral density. That can cause osteopenia or osteoporosis, and tragically, that bone loss is often not fully reversible, even after the patient recovers.
Now, for patients dealing with the binge-eating/purging subtype, there are other very specific physical clues left behind. Clinicians look for something called Russell's sign. These are calluses or abrasions right on the knuckles, caused by repeatedly inducing the gag reflex. On top of that, constant exposure to stomach acid leads to severe dental enamel erosion and even swelling of the parotid glands in the jaw because they are just overworking to produce saliva due to the frequent vomiting. These are incredibly stark, visible indicators of the trauma the body is being put through.
But perhaps the most staggering statistic regarding the toll of anorexia nervosa is just this single number, 18. This represents the psychiatric severity of the illness. The risk of suicide in patients with anorexia nervosa is approximately 18 times higher than in control groups. 18 times. When you pair that with difficulty concentrating, depressed mood, and obsessive-compulsive features around food, this deeply somber number is a harsh reminder that the neurocognitive and psychological pain of this illness is just as lethal as the physical starvation.
Section 3. The hidden metabolic crisis. Let's talk about the chemical imbalance.
We've seen the outward signs, but the internal chemistry is where the immediate acute dangers often hide. And this brilliantly illustrates how different eating disorder behaviors disrupt the body's delicate chemical balance in very specific, dangerous ways. The American Academy of Pediatrics points out that simple dietary restriction and dehydration lead to hypokalemia, a really dangerous drop in potassium. Self-induced vomiting causes a loss of gastric acid, triggering metabolic alkalosis, where the blood literally becomes too alkaline. Conversely, laxative abuse flushes out bicarbonate, which leads to hyperchloremic metabolic acidosis. Basically, every single behavior pushes the body's blood chemistry toward a totally different, life-threatening extreme.
When we look at the prevalence of these lab abnormalities, the data is striking. To put into perspective, a recent systematic review found that 17% of patients present with hypophosphatemia, 15% with hypokalemia, and 13% with hyponatremia. Overall, patients with eating disorders have 3 times higher odds of experiencing any of these dangerous electrolyte imbalances compared to control groups. And to be clear, these aren't just minor vitamin deficiencies. We're talking about the direct precursors to arrhythmias, complete muscle failure, and neurological collapse.
This internal chemical fragility sets the stage for one of the absolute most perilous phases of treatment. It's a major clinical paradox known as refeeding syndrome. You would naturally think that giving a starving person food would immediately fix the problem, right? Well, actually, if you attempt to fuel a starved engine too quickly, it can cause catastrophic electrolyte shifts. The sudden reintroduction of carbohydrates triggers a massive spike in insulin, which then forces phosphorus out of the blood and into the cells. This acute drop, known as hypophosphatemia, can cause severe tissue edema, seizures, or even congestive heart failure.
And the metabolic dangers don't even end there. Often, patients who are driven by this intense fear of clinical intervention will actually try to falsify their weight at doctor's appointments by drinking excessive amounts of water right beforehand. This water loading adds another severe layer of danger. It causes dilutional hyponatremia, which is a critical drop in blood sodium levels that disrupts the body's entire osmotic regulation. In a worst-case scenario, that can lead to central or renal diabetes insipidus.
Section 4. Paths to recovery. What are the evidence-based treatment options?
Despite these immense physical and psychological hurdles, recovery is absolutely possible. So let's look at the medical lifelines and the clinical protocols that provide hope. Treatment here is always a multidisciplinary effort, focusing on nutritional rehabilitation first and foremost. But the psychological approach really varies depending on age. For adults, guidelines support a few specific psychotherapies as first-line treatments. That includes cognitive behavioral therapy for eating disorders, a specialized program called MANTRA, and Specialist Supportive Clinical Management, or SSCM. None of those is vastly superior to the others for adults. However, for children and adolescents, the absolute gold standard first-line approach is FBT, family-based treatment. So the crucial point is why family-based treatment is so heavily favored for younger patients. And the answer is right there in the data. FBT achieves an incredible 48.6% remission rate at the 6 to 12-month mark. This significantly outperforms standard individual treatment, which only sees about a 34.3% remission rate in that same time frame. By fully integrating the family into the refeeding and therapeutic process, the outcomes for adolescents just dramatically improve.
Now, you might be wondering about medication. While this quote perfectly summarizes the current medical consensus, pharmacotherapy has a limited adjunctive role. No medication is FDA-approved for anorexia nervosa. While some antipsychotics have been studied, the evidence for their benefit is simply insufficient, and most importantly, common psychiatric medications like SSRIs, which are typically used for depression and anxiety, are generally completely ineffective in a malnourished state. The starved brain literally just doesn't have the biological building blocks required for those drugs to work. Nutritional rehabilitation must be the absolute non-negotiable priority.
We've seen how anorexia nervosa ravages the body's systems, radically alters internal chemistry, and demands a rigorous, evidence-based approach to recovery. It is a profound physiological crisis driven by intense psychological pain. So, I want to leave you with this thought. How might understanding the deep, systemic reality of anorexia nervosa change how our society, our healthcare systems, and our communities support those fighting this incredibly complex illness? Thank you so much for joining me on this explainer. Keep learning, keep asking questions, and I'll see you next time.